Hello there guys, I'm Kamran Bhopal again, and today we're going to discuss the history and examination of hematuria. This is an outpatient scenario, and usually this is combined with a bladder cancer scenario, so the history may be directed to that, and you can modify this history accordingly. But when I present this history to you, this will be visible hematuria in which I do not know where this is coming from, so I would then risk stratify it accordingly. I would risk stratify for renal cancer, I would risk stratify for bladder cancer, and I would risk stratify for prostate cancer. So it's good to know all of the different ways how you can risk stratify for all cancers. Some of the risk stratification questions are same for bladder and renal, so I won't repeat that. You can start with the risk stratification of bladder cancer and then move on to renal and then move on to prostate cancer and adjust your history accordingly. But more or less the rest of the history remains the same. So the scenario will come something asking about, the patient has presented with visible hematuria, or the patient has presented with persistent non-visible hematuria and on dipsticks, and the GP has referred it on to you. But whatever way it presents, as far as you know the risk stratification and how you are going to look into visible hematuria, that's more than enough. And I would now start the history for hematuria. I would like to see this patient in the 2-week wait clinic with ideally a urology specialist nurse. I would look at the referral letter and any previous investigations, imaging that is present on our electronic system. I would check the patient's understanding and confirm their identity. Hematuria is a urological cancer unless proven otherwise, and my assessment will reflect that. I will ask whether it is visible or non-visible hematuria, whether it is painful or painless hematuria, and whether there is any clots present. I would also ask for the onset, duration, and progression of these hematuria symptoms. I would rule out urinary tract infection, asking for dysuria, foul-smelling urine, flank pain, temperatures. Also ask for any sexually transmitted infections, sexual history, trauma history, menstrual history, and also ask some questions about symptomatic anemia. I would then ask for red flag symptoms such as weight loss, night sweats, anorexia, bone pain, and leg swelling. I would then risk stratify for all urological cancers, including bladder cancer, asking about exposure to aromatic amines and chlorinated water, smoking, schistosomiasis, family history of bladder cancer, etc. I would then risk stratify for renal cancer, keeping in mind obesity, hypertension, dialysis, occupational exposure to asbestos and cadmium, and other genetic factors such as von Hippel-Lindau disease, Birt-Hogg-Dube syndrome, and hereditary papillary renal cell cancer. I would then risk stratify for prostate cancer, keeping in mind the age, ethnicity, and family history of prostate cancer. I would then ask for past surgical history for any urological surgery, stones, infection, pelvic irradiation, and a medical history of renal disease such as glomerulonephritis, dialysis, etc. I would also ask for medications such as anticoagulants and phosphamide and any allergies. I would then check the social history of the patient, generally thinking about alcohol intake, obesity, performance status, and general fitness for surgery, and close the history asking about the ideas, concerns, and expectations of the patient. So this is how you would take a history of visible hematuria, and I hope that you've gained something from this, and we will do a separate video in which I would let you know about how you would move on to the questions that they may ask you, and the staging and grading and risk stratification of different types of bladder cancer. This is a huge topic, and is usually asked in the outpatient but also in the clinical skill station before you go on to telling about TURBT. So a very important station to remember, and I will do a separate station discussing the questions. All the best. See you next time.